Hello, good afternoon, everyone, and welcome to the Independent Sage briefing. A new IPPR report released this week has found that we are getting sicker and poorer as a nation. What does this mean for the UK? Has the pandemic had any role in this? And what does the picture look like regionally? In the briefing today, we'll be considering these and other related questions, looking at deprivation, health, and regional inequality in relation to the COVID pandemic. But before we get to that discussion, as always, we have our wizard with the numbers, Professor Christina Pagel, with the latest COVID numbers and trends for us. Over to you, Christina.
Thank you. Right, let me share my screen. Okay, so today I'm just going to go quickly through vaccinations, the latest on prevalence, how much COVID is around, hospital data, and then I'm just going to talk a little bit about deprivation to set up the discussion with our special guests later. Right, vaccinations. Well, basically, nothing is happening. There aren't many vaccinations going on. And there are only really tiny increases now week on week. And that is quite disappointing given we're only at just over half of 50 to 64-year-olds who've taken up the offer of an autumn booster. So that's where we are there. In terms of prevalence, the latest ONS infection survey came out today. This is it showing from last September. So we're here and you can see we're still at kind of relatively low levels compared to where we've been, but there are now signs of a recent uptick. And if we just look at the last 4 weeks, you can see that apart from Scotland, every country's gone up a bit. And the thing is that for some reason, the latest infection survey is only 4 days after the previous data, so it's not a full week. So actually, the fact that we're seeing increases in 4 days does imply that we are actually increasing again, but not super fast, at least at the moment. Regionally, I just wanted to show you the English regions. It goes from 1.9% in London down to 1.6% in the northeast. So there's not massive differences, but it's the first time in a long time that London now is the region with the highest prevalence. And the other thing I just wanted to point out is that the 3 regions with the highest prevalence, London, Yorkshire and Humber and the southeast, are also the regions that are going up the quickest. So they're seeing the greatest rate of change. So just keep an eye out on those over the next few weeks. And I also just wanted to highlight the latest schools data. So this is a number of pupils in state education, both secondary and primary, absent for any reason. This isn't just COVID, this is any reason from school. So this is the last academic year, and you can see the last COVID peak we had in July, really high numbers of students off sick. It's been much, much better this term, but still higher than the previous pre-pandemic average, which is this green line. And you can see in recent weeks, this has been going up. Now, the likelihood is that this is going up not necessarily from COVID, but from things like RSV, rhinovirus, and the terrible colds and other respiratory things that have been going around in schools, but just saying that actually schools are still being quite disrupted by respiratory viruses. On hospitals, this is the number of people in hospital per nation, per population over time. This is the latest data. So you can see actually, apart from Northern Ireland, which is actually a week behind, you can see it is now starting to creep up in all nations, England, Scotland, and Wales. If we look at the number of daily hospital admissions with COVID in England up to the 5th of December, you can see this is going up now. We're still at about, I think, a third of people being in there primarily because of COVID, but it is an issue. And what we're seeing, it's been an issue with Omicron this whole year, but again, we're seeing an increase in the number of people who are catching COVID in hospital. So this is the latest data on that. So over a third of people who count as a hospital admission with COVID are people who caught it in hospital. And that number is going up faster than overall hospital admissions. So there is an issue with trying to stop infection spreading in hospital. And that is likely partly because Omicron's really infectious, but also I imagine because hospitals are really full. And if they're really full, it's much harder to isolate people who are infected. And if you're in hospital for other reasons, you really do not want to get COVID on top of it. And I just wanted to talk about flu quickly. This is flu hospital admission rates in England from UK HSA data. This is 2019-2020, so a peak just before Christmas. This is 2018-2019, a peak just after Christmas. This is this year here, so we're kind of on track to be very similar to 2019-20 at the moment, but it looks like it will be a significant flu season this year. The slightly good news is that it looks like rhinovirus and RSV, which are other respiratory infections, are declining. The latest numbers are down for now. So we'll see if that trend continues. This is the first week they've come down. And the latest performance indicators for the NHS came out yesterday as well. I'm not going to go into it in great detail because we discussed it last week, and also Kit Yates from Mitigation has also done a really long detailed thread on it today, so go check that out. The good news is that it looks as if things are stabilizing over the last month, so numbers aren't really going up or they're going down slightly, but the bad news is they're stabilizing at a bad level, so quite a serious level, and we still have a record number of people waiting for treatment in the NHS, 7.2 million people. So now I'm just going to discuss deprivation. And I'm just going to go through various measures over the pandemic and separate them out by deprivation and show you basically what has been going on. So I'm going to start with just protection from vaccination. And this is the percent of over 18s who are unvaccinated by deprivation quintile in England as of July 2022. And you can see it's almost 3 times as many people in the most deprived areas have not had any vaccine doses compared to the least deprived. So people are much less protected, both from getting COVID, but also from the severe consequences of COVID. And then I wanted to highlight this academic study that was done with the ONS infection survey on deprivation, but particularly looking at its impact on work and exposure, infection, and then illness. And the really important thing about doing it via the ONS infection survey is that it takes away the problems of expecting people to come forward for testing. And we know that people in more deprived areas are less likely to come forward for testing. And so that can really skew case data. So this is a study that was done on ONS infection survey. It goes up to January 2022. And it looks only at people aged 16 to 64 years to capture kind of working years. So the first thing they looked at is exposure to COVID during that time from April 2020 to January 2022. And you can see that people in the most deprived deciles, so the tenth of the populations that's in the most deprived areas, a much higher likelihood of having to go to work during the pandemic, and also going to work in a place where they can't physically isolate. So that leads to more exposure. And the other thing that they showed, which I think is really important to mention, is that those in the most deprived areas were also more likely to have lost their jobs or to have been furloughed between April 2020 and January 2022, and then much less likely to have been re-employed afterwards. And the biggest differences were seen in the hospitality and social care sectors. So there was a real economic impact on people in the most deprived areas as well. In terms of then prevalence, in terms of getting infected, you can see really big differences. Even in the Omicron era, when it seemed like everybody was getting COVID, you can see that significantly more people were infected in the most deprived areas than in the least deprived. Now, the numbers for Delta are higher than Omicron because this study ends in January 2022, so only a month and a bit of Omicron. So these numbers will be much higher if you went on now, but you can still see that there is that deprivation difference there. And then the consequences of that you can also see. So people in more deprived areas are more likely to contact the NHS and much more likely to have actually been admitted to hospital. So again, you're seeing this feed through to severe outcomes as well. And this is also true for mortality. This is now looking at differences by mortality up to July 2022. This is age adjusted, which means it takes into account the fact that people in deprived areas are likely to be a bit younger. And it also is death certificate data only. So it's where COVID is on the causal pathway of death. And you can see that the mortality rate in those in the most deprived areas is more than twice that in the least deprived areas. And you can also see this feed through into long COVID. So again, those in the most deprived regions are reporting significantly more issues with long COVID than those in the least deprived areas. And I just want to show you this chart by region in England, because you can see there is a pattern there as well. So this is the percentage of people reporting long COVID at least 4 weeks by English region. This goes the latest data up to November this year. And although there's not a massive difference, there is definitely a gradient here going from almost 4% down to under 3%. And the key thing is that the regions that have the highest levels of long COVID are basically the north of England and West Midlands. So to summarise, there's hardly any vaccination ongoing now, and only just over half of 50 to 64-year-olds have been boosted this autumn. Prevalence and hospital admissions both suggest that we are entering into another wave, but still quite early in that wave, and we don't know how high it's going to get. As well as COVID, flu admissions are increasing. We're still seeing more flu, but thankfully it looks as if RSV and rhinovirus are reducing, at least for now. NHS strain in general seems to be stabilising, according to the latest indicators, but it's stabilising at a very severe level, so I wouldn't necessarily call that good news. And then the COVID pandemic has had a massive disproportionate impact, where those in more deprived areas have fared much worse on pretty much every measure. And with that, I will hand over to Sheena and Zubaida.
Thank you, Christina. That's quite sobering, really. Not only the data that you showed on deprivation and differences between north and south, but also the data on vaccination. That's really worrying that so many people are not yet vaccinated. And obviously, I already also alluded to the new IPPR report that recently came out, and actually one of our guests has contributed to this. And as you've seen from Christina's presentations of the numbers, that the north and areas of deprivation also have, for example, more long COVID, and long COVID's been shown to disproportionately economically impact people in deprived areas. So there's lots and lots of impacts to be felt. So today we're going to be focusing on the link between health and wealth in England and Wales, the short and long-term consequences of health inequalities, and how it's becoming the big divide between regions, and what regional public health strategies have been deployed to address it. And to do this, I'm delighted to say that we've got two amazing guests joining us today. Professor Arpana Verma, who is the Clinical Professor of Public Health and Epidemiology and Head of the Department of Public Health here at the University of Manchester. And she's really passionate about working with communities with a focus to reduce inequalities. And we also have Professor Clare Bambra, who is a Professor of Public Health at Newcastle University and has a new book coming out in March 2023 called Northern Exposure, COVID-19 and Regional Inequalities. So I now invite Dr. Zubaida Haque to join me for the main session, which we will both be co-hosting. And it's going to be this discussion on COVID and implications on health inequalities.
Thank you so much, Sheena. It is fantastic. We're really, really excited to have our guests with us today, Professor Arpana Verma and Professor Clare Bambra. We've got lots of questions, but don't worry, not too many, to ask you. And I thought we could start with you, Professor Clare. Well, first of all, you co-led several reports on the unequal impact of the North. And you came up with some really interesting and sobering findings. So I was wondering if if you could just perhaps explain to us what you mean by the unequal impacts of the pandemic in the North, and what you mean by something that you've talked quite a lot about this week on the news, I think, by the big health and wealth divide.
That was the big health and wealth divide. Sorry, Wi-Fi keeps going out.
Oh, sorry, am I going out again with my Wi-Fi? I'm sorry. So, yes, over to you, Professor Bambra.
Oh,
Thank you. I do have some slides to share to present some of the findings from our work, if that's okay. If they could be shared, please. And thank you for having the topic of discussion on the North and COVID today. That's really useful. Okay, so thank you. So I'll be very brief because we've already had one presentation, but this follows on nicely from Christina's discussion of deprivation. And together with colleagues from the universities of Manchester, York and Liverpool, the Northern Health Science Alliance and the Northern Applied Research collaborations, I've been doing some work looking at the disproportionate impact of the pandemic, both in terms of COVID itself and also the kind of collateral damage caused by the lockdowns and restrictions. We have a free to access book, which will be published in March. So it's a plug, but you don't have to pay. So watch the space on that one, which brings together basically what I'm going to tell you about today, but obviously in a longer format. Next slide, please. So in our work, we were studying initially the regional inequalities in COVID-19 mortality. And we were looking firstly at data over what's broadly the first year of the pandemic, so March 2020 to February 21. You can see in the maps here the COVID-19 mortality by local authority, with particular clusters in around London, Northwest and up into the Northeast, broadly patterning what you'd see usually with all-cause mortality as well. But when we dug into it more deeply from a regional perspective, then the three northern regions, so that's the Northeast, the Northwest, Yorkshire and Humber, overall had a much higher death rate from COVID-19 compared to the rest of England, so around 30 per 100,000 higher mortality rate from COVID. So that's kind of inequality one. Next slide, please. However, within this, we've also found an interaction between deprivation that Christina was talking about and region. So as you can see in this slide here on the bar chart, then this is showing us all-cause mortality by region, but by deprivation within a region, and also the same for COVID. COVID's in red. And again, it's over this initial 1 year of the pandemic when mortality was highest across the country. So here we can see, if we focus on mortality, that the deprived areas in the north had a higher COVID-19 mortality rate than similarly deprived areas in the south. And we can also see that that's the case for all-cause mortality as well. And what we can also see is that more affluent areas in the north and more affluent areas in the south have broadly similar mortality rates. So when we talk about a north-south health divide, we're really talking about deprived areas in the north compared to deprived areas in the south, and obviously compared to more affluent areas within the north and within the rest of England. So we call this the amplification of deprivation in relation to COVID. Why were COVID deaths higher in more deprived areas in the north than equally deprived areas in the south? So that's the second aspect of our research. Next slide, please. Christina's already touched upon this in terms of what we're seeing now in terms of morbidity as a kind of outcome of the various waves of variants that we've had. Christina's data was looking at COVID, long COVID of 4 weeks duration. This is looking at when you put it all together. So some people are reporting it for over a year, for example. And if we do it that way, then the north-south divide becomes even clearer than in the 4-week data. So here you can see that the Northeast has the highest rate of long COVID of any duration, the Northwest, Yorkshire and the Humber, and the North there in green, much higher than the English average. So this is going to be potentially a much longer term burden, potentially playing out in some of the data we've seen on increases in people falling out of the labour market due to ill health, which, as the IPPR report showed this week, is again higher in the Northeast, paralleling these long COVID outcomes. Next slide, please. So in our work, we haven't just looked at the immediate impacts of the pandemic, as in impacts of COVID itself. We've also been looking at some of the knock-on effects, mindful of the big mental health impact that the pandemic had. So there have been various studies showing, for example, impacts in alcohol use during lockdowns, big increases in reporting of poor mental health across all different socio-demographic groups. And we wanted to analyse this from a regional perspective. So in our recent report this year called The Parallel Pandemic, which looked at regional inequalities in mental health, we found that there was much higher reporting of poorer mental health increased across the country in every region during the lockdowns, as you would expect. However, it increased more in the 3 northern regions than in the rest of England. And then over time, as the restrictions reduced, the mental health levels in the rest of England went back to their kind of pre-pandemic, so there was a decline. In the north, there was a small decline, but the mental health burden in the north is still higher than it was before the pandemic. We also found different intersections, and that it was particularly worse for younger people in the north, much more likely to be classified as having a severe mental health problem, and also particularly for ethnic minority groups in the north, specifically ethnic minority women. So it's not just COVID itself that's had an unequal impact. Some of the restrictions and measures that were taken have also had an unequal impact. And we calculated the economic impact to be around 2 billion from the additional burden of poor mental health that we're experiencing in the north. And some of that is perhaps also playing out in the increased worklessness statistics that were released this week. Next slide, please. We've also looked at regional economic inequality. My colleague, Dr. Luke Mumford at University of Manchester, has done a lot of work in our reports looking at what happened to the economies of the north compared to the rest of England, particularly during that first year of the pandemic. And in these 2 charts, we can see how the unemployment rate increased in England during the first year. But you also note that the north started off in a worse position with higher unemployment. The pattern's the same across the north and the south, but obviously at a much higher rate in terms of the north. So there's been an additional burden of unemployment for us. In terms of pay, then wages actually declined amongst the labour force in the north, whereas they went up in the rest of England. And so there was a very immediate economic impact, potentially because of more people falling out of the labour market, as the data which Christina presented from the workforce survey, I think, also reinforces. Next slide, please. So this is the final slide, is just to conclude that it's been a very unequal pandemic. The north has been far more exposed to the impacts of the pandemic, both in terms of COVID-19 mortality, morbidity, outcomes from long COVID, mental health burden, as well as productivity and economic costs, all of which are likely to have a long-term scarring impact on what is already the more deprived region within the country. It's particularly concerning, I think, the impacts that we've found on the mental health of younger people and ethnic minorities in the north. And if you want to read more of this somewhat depressing research, then the book will be available free in the new year, and we will be doing some more presentations on the work as that unfolds. Thank you.
Thank you so much for that, Claire. That was absolutely fascinating, if a little disturbing. And one of the things that really struck me that you said was that you highlighted the unequal economic and mental health effects. And obviously restrictions will have played in with that, and arguably there were longer restrictions in some of the areas that you mentioned, and I certainly saw some of that myself. But could you tell us a little bit more about what that looked like and what it means for people who experience the brunt of the pandemic in this way?
Yeah, so on average, during the kind of first year when the country was being variously exposed to lockdowns and social distancing, then the north on average had an additional 6 weeks in the most severe restrictions. So I can remember, for example, in, I think it was 2020 in the winter, all of the north was in what was tier 4, which meant basically full on lockdown. Meanwhile, in London, people were able to go out ice skating and go to social distance restaurants. Now, that has an economic impact clearly on the businesses in the north who weren't able to be open compared to businesses in the south. And it also would clearly have an impact on the mental health of the population, who are having an extra 6 weeks locked up away from family, friends, workplace, and so on. Now, that's not in itself necessarily a criticism of the need or the use of the restrictions, but it is pointing out that there has been, other health impacts of the pandemic, which may or may not have been able to be anticipated.
Zubaida?
Oh, thank you. Sorry.
Oh,
yeah,
you've frozen again.
Is it okay?
Yes, right now.
Right. Thank you. Thank you so much, Professor Bambra. That was really fascinating, and at the same time, really worrying in terms of the long-term health inequalities and the subsequent impacts. Now, Professor Arpana Verma, you've also had a big interest in the link between deprivation, health, and inequality. And just this week, also, I think you contributed to a report which examined the mitigation strategies implemented by the directors of public health in different areas across England, but with a particular emphasis on areas of high that had, if you like, more sort of if you could.
Oh, do you want to just go back again? Sorry, you went black.
Oh, I'm so sorry. I'm so sorry. I don't know how much of that you got.
I'll tell you what, I'll just do that question quickly. So I think you've done this amazing report, and you showed that there was sort of the mitigation strategies, you looked at them, that were implemented by the various directors of public health across England. Why do you think that the areas with higher COVID rates fared so badly in the pandemic? Do you think there could have been more that could have been done to take a more place-based approach to mitigation and support?
Thanks, Sheena. That's great. So if I just show you a couple of our slides on enduring prevalence, because I think one of the big things that we've really tried to work out is what's driving some of these issues. I'm hoping that this is now sharing. Is that working in terms of share screen?
Yes.
Yes, it is.
Brilliant. So this report that you mentioned is part of our national core study looking at workplace and COVID that we are partners in. So please do come and have a look at our website. And really looking at COVID is a blueprint for inequalities of our time. And our thanks to the study team who did this phenomenal work, but we must say thank you to the directors of public health who, during this really important time for them, trying to deal with the pandemic, we're so grateful that they spent time talking to us for us to understand what was happening. So what we took were areas of the highest prevalence and matched them to similar areas that didn't have the increased prevalence. And I'm afraid to say it's very much as the data that Clare showed us. We sort of know what these barriers are in terms of the mitigation strategies, because what we've got is a classic example of the wider determinants of health having that impact on how those areas of enduring prevalence during COVID really took shape. So if you imagined our classical model what we found from speaking to those experts that really know their populations is that it's the classic issues around housing and some of the key components of being able to understand the messaging. And what we're trying to look at in our study are those drivers to the regional variations and the link up with social determinants. And I think one of the key things that was mentioned in the data that you showed early on, vaccines. This is in our gift that we have a phenomenal vaccine service. And some of the work that we've been doing, as well as looking at enduring prevalence, is what's driving this lack of confidence of why people aren't taking up vaccines. And these are down to those structural inequalities. Are we talking to our populations in the right way, rather than in the way that we want to talk to them? And who are the best people to talk to our populations? And sadly, what we know is that there's been a huge campaign through social media, but also normal media and the sort of post-truth era that we now live in, where people probably trust the evidence that's produced by non-professional sources are trusted much more than those individuals that might be out there in the communities promoting vaccinations. And I think one of the key things that we found when we looked at mitigation from the endurance prevalence work is very much around how are we communicating with our populations? How are we involving them in those communications, and are we speaking the right language? Trust comes up each and every time. Who are the trusted individuals? And sadly, I don't think it's people like us. I think it's people within the communities that have the influence and are able to challenge some of the things that might be propagated in social media and mass media campaigns that really discredit the huge benefit of things like vaccines. And I think one of the key things from our work with communities is that we didn't, and we still aren't, getting it right. And so working with our local authorities who definitely know their populations and getting that into those areas, because I think one of the key things is that we become so reliant on data to fix things. But what we know is it's people who fix things, and being able to build that trust again and understand where they're coming from would be the key thing from our research. Thanks, Sheena.
Thank you, Arpana. And I think that resonated with me so much. I mean, I've done a lot of work with British Society for Immunology, and we did a lot around vaccination communication and trying to get champions within communities who had the power, who were empowered, had the information, felt that they could talk confidently about vaccines. And it makes all the difference. And I do a lot of work with non-native English speakers. So I think this is music to my ears. But what can we do to ensure that this sort of work and dealing with the mistrust and these inequalities within communities can be addressed, because it is likely that we're going to have another pandemic. So what steps do you think we need to get in place now, Arpana? And also, please join in as well, Clare, because I think this is such an important question.
Yeah, thank you for that. I'll start off with a couple of things. What we found from doing our reviews of the literature, it actually doesn't matter which framework you use. The key thing is doing something with your communities by where we're actually listening to them. So one of the key things that I think becomes almost second nature to us is that very deficit approach. There's something wrong. There's something wrong because you haven't taken up the vaccine, or there's something wrong with the issues with the lifestyle factors that you've chosen. And so that comes from a very deficit approach, and it's the classical problem with healthcare that we will come in and we'll tell you what to do to make it all better. So a lot of our work has been around the asset-based approach and community development for empowerment. And so it's the classic thing that we've known about for over 55 years, Einstein's ladder, by where often we end up doing tokenistic community development and participation. We need to move it all the way up to true empowerment where the communities are telling us. And so that asset-based approach, and Sheena, you hit the nail on the head with a place-based approach. And it's something that we did with our communities, thanks to funding from what was Public Health England, utilising that approach by where we're building the trust, not just with the champions, but the people behind the champions as well. So really getting under the skin of those communities by engaging with them and using non-traditional methods, the walking, talking methods. Come and take me around your area, show me what your assets are. In one community, it wasn't the library, it was their takeaways that they classified as their asset. Come and show me what's best for you. Who do you listen to? And then the second thing is then to get the language in the right way so that we can start building that trust all the way back up again. And so many things that happen are very short term, and the fatigue that these communities are having from these very short term interventions, it's almost like when you come in again, it's like, oh no, not you again. What are you here to evaluate this time? So really thinking about how these things all join up and using things like photo elicitation. And if it is social media that is the influencing factor, using those approaches to be able to bring across the message that we want to do.
Thank you. And Clare, what do you think we need to do to be ready for the next pandemic? So just to follow on from that question, or Bill.
Okay, I'll just quickly say something returning to the vaccine uptake question that you originally asked, which is, yeah, of course, local public health teams need to be adapting to their communities. Arpana's completely correct on that. However, where's the actual national push? We just saw from Christina in the data that there's basically no vaccines being given out. We've only got 50% uptake in the over 50s. When am I going to be allowed my next vaccine? You know, these are, if you want to get one, most of us actually can't get one. And we had over 80% uptake in kind of the first, because there was big promotion, everyone knew about it, everyone wanted it. It's kind of like it's a secret thing that you have to go and find, and only, you know, the more educated, more middle class people seem to be going to do that. So there is a big role for the national government to actually get us access to the vaccine on an ongoing basis. So yeah, anyway, to return to your other point about what do we need to do to prepare for the next pandemic? Well,
easy question.
A very easy question, which of course the public inquiry is itself looking at the moment. The COVID inquiry module 1 is on about pandemic preparedness, looking at what went wrong, what went right, what we can learn from that. So I would probably say that I'll let them answer over the next few months, and they have their first public hearing in May, which people watching may also want to see that as well. But in terms of health inequalities, where I've got obviously more specific expertise, then one of the kind of underpinning issues in all of this, and quite potentially why we've seen this amplification of deprivation in the north, is about the underlying health conditions and the burden of key clinical risk factors that are not equally distributed, all of which is not being helped by people now experiencing cost of living crisis, not being able to heat their homes, not being able to have adequate food. This is all making us as a population, particularly in the north, more vulnerable because our immune systems are just being run down even more than they had been previously. So in terms of what needs to be done, in my view, we need a whole scale, absolute rethink of what public health is. And it isn't just about pandemics. It's about ensuring we have as healthy a population as possible. And a healthy population is also a more productive population.
Hear, hear. Absolutely.
Yeah,
agree.
absolutely.
Thank you so much to our guests. That was absolutely fascinating and engaging. And we're now going to move to our question and answer session. And we've actually got our first member of the public joining us. And this is Will Newcomb, who's going to join us and ask us a question. Over to you, Will. Can you switch your camera on? Excellent.
Okay. Thank you. The virus spread from China to the whole world. Alpha spread from the UK to the whole world. The pandemic is a global problem. Though the Chinese mainland stats show decreases in all infections over the last 10 days, the abandoning of mass testing will mean vast numbers of undetected asymptomatics will now be circulating and spreading the virus. Infections and deaths must be a result. What are your comments?
Thank you for that, Will. So that's a really important question. Christina, can you comment on it at all?
So I'm not quite sure what the question is about, whether we should, how we stop it spreading globally, or about the testing. I'm not quite sure what I'm answering.
Do you want to clarify, Will?
How does the panel feel that the recent changes in China might affect things more globally as well as in China?
Right. Okay. So I think China is in a really difficult position. They just have not vaccinated enough of their vulnerable population to weather a big wave without a lot of illness and death. But they're also in a situation where it's very, very difficult for them to prevent that, particularly given the protests. And so I don't really know what's going to happen, but I think they're in for a bad time. How it will affect the rest of the world, I don't know. I mean, they're obviously a sizable chunk of the population. I mean, I'm sure Danny and Steve Griffin can comment more on viral evolution than me and Aris, of course, but I'm kind of guessing that the way the virus might evolve in China is a bit different to how it would evolve in the rest of the world, because we have so much more pre-existing immunity, for good or for ill, that I'm guessing it'll find different ways, but I'm not the right person to comment on that bit.
I can maybe do you one sentence on it. Just that, I think anybody who's doing any kind of COVID-19 punditry is always trying to calibrate where we are between, let's all calm down. Maybe the stats show that it's getting better, and doom and gloom, which makes us very unpopular. But the simple answer is that wishful thinking is no basis really for public health measures. And I think what your question perhaps is getting at is that much as we'd like to talk about the pandemic in the past tense, if you've got trillions of copies of virus in millions or billions of lungs, none of us have any guarantee that the next, even more ghastly variant of concern isn't sitting in one of those lungs. The answer is it is. So the only question is how well it spreads from there, and no way of knowing. So yes, so if your question is this scary? The answer is yes, it is.
Stephen R first. Sorry, I think he had his hand just before you, Steve G.
Yeah. So if I can just broaden this a little bit, when you look at all the media discussion of what's been going on in China, they conflate the lockdowns with a zero COVID policy. Now, one of the things that we made quite clear in Independent Sage from 2020 onwards is that sometimes when infections are running out of control, yes, you need to take measures and you need to place restrictions. But so-called lockdown is not a zero COVID strategy, because if you just lock down and do nothing in the interim, then when you stop lockdown, then infections rise again. So it is a strategy which must go along with other things. And amongst the things that we advocated were, for instance, improving ventilation and clean air, improving vaccination and vaccination rollout, and so on. So I think what's happening in China shows us that actually a strategy for dealing with COVID can't be one-dimensional. We've made the point that it has to include vaccinations. It can't just be vaccinations. It's also got to be a safe environment. But equally, it can't just be lockdowns. And I think it's a very clear message that actually we need an integrated strategy, a vaccine plus strategy, and a single dimension strategy hasn't worked in China, and it hasn't worked elsewhere either.
Thank you. And Steve, did you want to add something to that as well?
Yeah, just quickly, I think that there's been a lot of talk around how we're in such a better place than China now, and that's absolutely true in terms of our vaccination coverage, etc. And we do also have a very complicated sort of network of immunity in our country as well, but that has come at a cost. We've had over 200,000 people die. We've had morbidity and all the rest of it. Okay. So yes, we can be more resilient to waves of infection now, and we're seeing that. But what I worry about seeing in China, as we saw in Hong Kong in spring, is a reminder that this virus only causes less severe disease in populations when they are highly immune. And unfortunately, China, they haven't got the vaccine coverage, as we said. They also don't have a particularly effective vaccine. And I am very, very concerned that we could see a huge public cost to allowing this virus going. They're not going to let it rip either. I think that there's much been made about this. A lot of the restrictions are actually fairly sensible and not as draconian as they were. They're still going to be testing. They're still going to be doing test and trace and things like that. So hopefully they can weather this storm. But I really do worry that we're going to see just how not mild SARS coronavirus 2 is very soon.
Thank you for that. Does that answer your question, Will?
Yeah, appreciate that. Thank you.
Thank you. Our next question comes from Michael Edwards, and he asks, most studies of COVID and deprivation use the IMD value or rank of the zone where the patient lives. Is this good enough, given that we know that various social processes, gentrification, council estate demolition, are making these zones less homogeneous? Is there no way of relating these studies to the individual or household income or deprivation situation? One perhaps, Clare, you could perhaps address.
Yeah, that's a really important question, and it draws into the idea of the ecological fallacy, that what happens at the area level is also true at the individual level. So, not everyone who lives in a deprived area is themselves deprived. You can all probably think of that in your own towns and cities. There might be one street that's actually quite affluent, but it's in what we would classify as a deprived area. So there's some important issues there. The reason it's done is because obviously that's a lot of how we get the data, because it can be anonymized at an area level. But there are other studies that have been done using different data sets, such as the biobank data sets, such as the data sets looking at NHS workers, for example, where you can have much more nuanced detail about the individual in terms of their income, their education, their ethnic group, for example. And these studies have found, unfortunately, at the individual level, kind of equally true to what we find at the geographical level. So people from lower income, from low occupations, more likely to have adverse outcomes from COVID. And even when we control for people's income, we see an excess mortality amongst some ethnic minority groups. But fantastic question. I wish I got such good ones from my medical students.
Arpana, did you want to add something?
Thanks, Sheena. Yeah, and just to add to what Claire was saying with respect to that whole focus being down at individuals and the use and abuse of these indicators. So when we're looking at individuals, those figures like the IMD very much are based on populations, and it's something that I know often gets reported on. But one of the key things within our research on urban health is that whatever geographical layer you look at, the within geographical differences are much wider than when you're looking at what's happening in larger areas. So you get this masking effect. So there's that issue. So trying to get the data that's answering the correct question in the right way is something that's often reduced down to routine statistics. So I think that's something by where we've really got a big piece of work to do, but we've got the tools to do that. And the second thing, just to say, I'm sure many of you all know that the Office of National Statistics will be redrawing some of those lower geographical boundaries from the 2011 to the 2021 census. So also comparison over time is going to be interesting as we see differences, because we've had quite a lot of regeneration, especially in our city centres, and the gentrification, the movement of populations out of the hubs of our cities into the suburbs to allow for this massive regeneration. So within Manchester, the significant changes to our city centres, huge. So I think that's a question is very much watch this space, because I think as we move into this next set of data analytics using big data and artificial intelligence in line with actually hypothesis testing, so we don't get the wrong inferences from looking at these data, is a really important step for public health going forwards.
Thank you. I'm going to move on to the next question now, and that's quite different, but it's very topical. So the question comes from Felicity Page, and she says, are there any thoughts from you about the relationship between COVID-19 infections in children and the recent high number of hospital admissions of children with strep A? And she also adds that she's not entirely sure what strep A is and if it's a common infection. So it might be worth starting with that first. Who would like to take that? I'm kind of looking at Steve G already.
I thought that might be Helen's. No, okay. Well, strep A, yes, it's an infection that's very common amongst us, but isn't very commonly severe. So we see waves of infection usually slightly later than we're having them now. But one thing about these bacteria is they kind of change where they are in the body and they become more invasive and they start to secrete more toxins. Usually when your sort of body is sort of perturbed by something that that knocks it for six, like a really bad virus infection. So a lot of severe strep A follows things like chickenpox and influenza, for example, when you get pneumonia. This is really stretching my bacteriology. Thanks, Sheena. But yes, but the the upshot being that seeing more severe cases is obviously worrying, because there's probably been a lot of respiratory viruses going around at the moment. There's also a lot more people who haven't maybe had strep A as much recently because of various restrictions, but I'm not sure how much of a factor that plays really. It's possibly more to do with flu moving around and causing problems, I think.
Well, perhaps Helen should come in, because she's really at the front line dealing with these infections.
Yeah, I mean, strep A is a bacterium, and quite a lot of us just carry it around with us normally. So if you swabbed everybody's throat, sort of somewhere between 1 in 10 and 1 in 20 of us you'd find some strep A, but we're not ill with it. Okay, so that's the first thing. It is a fairly normal bug, and every year, unfortunately, there are some people who get really severe forms of it, and we don't quite know why those people do. There is definitely something about being weakened by having a virus, quite often a respiratory virus beforehand, and then you get a strep sore throat, and that can become very invasive. In most years, unfortunately, a few people die. This year, more than we expected, but it's not yet clear whether that's out of a kind of normal fluctuation or whether it really is something different. We haven't found any new bugs. There's no new variant of it. And so, you know, some of us at the kind of coal face where we're seeing a lot of children with sore throats, and they're no different than all the other children with sore throats that we've seen every other year. There is a little bit more strep A around. There's probably a bit more recognition of it because sometimes we may not be picking it up. But I think I'm slightly frustrated with the degree of panic that's been generated by this, because it does mean that lots and lots of parents are being really worried and bringing their children to us. I actually haven't handed out, I've seen a lot of children with sore throats, and I haven't handed out any antibiotics for sore throats yet, because I was very happy to say they weren't strep sore throats. You can't always tell clinically, but I was quite convinced mine weren't. I don't know whether that's answered your questions at all. There probably is a relationship between underlying or previous illnesses and getting strep A. Whether that's got anything to do with COVID, less sure.
Okay. I'm going to do one last question, and this comes from J. O'Hagan. I don't know what the J stands for, and they ask, the NHS says to avoid crowded places. Do we have any thoughts on what counts as crowded indoors? And also the NHS talks about wearing face coverings when it's hard to stay away. Any idea what far away means here? Who would like to take that question? Helen.
Crowded probably means A&E. Sorry. Steve, you probably had a more sensible answer to that.
No, I was going to say that as well. No, yeah, it's a balance. So it's obviously going to be a balance between the number of people and the relative ventilation of the area that you're talking about inside. So things like a packed bus with no windows open, bad idea. And this is because we know that the majority of transmission of the virus is through the aerosol route, so it hangs around in the air. So if you're not clearing that air, that's gone. And this is why it's a bit of a fallacy about the whole social distancing idea. If you're not in a well-ventilated place, social distancing doesn't do very much unless you're trying to avoid people sort of sneezing and coughing in your face. So really try and improve the ventilation anywhere you're going. Wear a filtering, well-fitted mask if you have any doubt whatsoever, because it's as Christina said earlier, cases are on the up.
And Steve R.
Yeah, right at the beginning of the pandemic, SPI-B, the behavioural advice group to SAGE, made one or two points about communication, and one of those is very simple. It's that communications are no good. If you read them, then you don't know what to do with them. And I think this is a classical case of that. In fact, we did a very specific critique of the government when they changed from stay at home to stay alert. I mean, stay at home, you know what it means. It means stay at home. Stay alert. Well, how the hell do you stay alert to a virus, you can't see and you can't sense? And similarly, I think we've forgotten basic messages about health communication. That health communication must leave you in a situation where you don't have to ask questions like this. Now, also, and I'm trying to remember where it was, other people might remember it, but there were some very good, if you like, diagrams pointing to the relevant parameters in terms of the degrees of risk. And there are a number of factors. I mean, one has already been pointed to, it's ventilation. Second is crowdedness. A third is how long you're there. If you're only there for 5 minutes, it probably doesn't matter as much. A fourth is what you're doing. If people are shouting and talking very loud, as in a pub or a club, that also is a risk factor. So it's not as simple as saying there's risk or no risk. There are a number of factors. I think it would be helpful to be very clear about those factors. I think you could do something like develop an app so you can look at context, plug in the parameters and see, how risky it is. But in a sense, if in doubt, play safe. And don't just play safe for yourself, play safe because over the Christmas period, you're going to be visiting elderly relatives and vulnerable people. And okay, getting sick might not be that serious for you. It might be very serious for them. So look after each other, be careful, and look at the various parameters, I think are the key messages to give out.
And I think that's a wonderful message to close, and obviously take your vaccine if you're offered it. I think that's all the time we have for questions today. So thank you again to our amazing guests for joining us and sharing their expertise on the subject. And as always, to our brilliant panel members for their insights. And we also thank the members of the public for their questions. We will be back next week, same time, same place. Till then, keep safe.
Bye.
Bye.